Hey everybody, it's Kirby. For those of you who don't know me, I'm the behavioral health educator at the Children's Hospital. I'm just going to talk to you guys today about suicidal ideation and patient aggression and how we can keep our patients safe and help to keep ourselves safe as well. So the first thing I want to talk to you guys about is the policies. Recently, we did update the suicide policy, so you may have seen it released on Policy Tech. It used to be one whole policy, which was BH.002. Now it has been split into two different policies. One focuses on like the risk assessment piece of the suicide patient, and that is BH.002. Then the other one focuses more on the precautions and maintaining safety of the patients via precautions. And so that one is going to be BH.017. So if you're looking for the policy related to those precautions, it now is split into two, so just to clear up some confusion on that, when you review the policy, you definitely want to look at both of those because they both apply to our setting in different ways. And then also, you just want to kind of know about the Code Purple policy as well as our purple.sop related to identifying aggressive patients, whether that means it is the patients themselves or their family members, things like that. So first, let's talk about identifying patients at risk. So if we're going to identify patients at risk for suicide, we want to make sure that we are using the Columbia suicide screening tool appropriately. And so I just want to talk to you guys about that and make sure that we are doing it correctly. So in that policy change, we did change the policy to say all patients ages 12 and older will receive the Columbia screening, and then if clinically indicated, if they are under the age of 12. So not to say that kiddos under the age of 12 aren't suicidal or don't attempt suicide, because we know that they do. However, we are not going to use the Columbia screening tool on anyone under the age of 12 unless it is clinically indicated, meaning that there is some reason why we would think this patient might be a suicide risk. So if they're making suicidal statements or potentially coming in with a third-party statement that they are suicidal, then of course we would want to do the Columbia screening tool on them as well. But every patient ages 12 and older needs to receive this assessment at admission, upon transfer to a new unit, and then at least every 7 days during their stay. It is really important that we ask the questions on the Columbia tool exactly as they were written, because they were written that way intentionally. So the Columbia scale is designed using evidence-based practice to identify where the patient falls on this, I like to call it the scary scale, right? So when you're assessing the patient, the questions are designed to elicit certain information to identify where the patient falls on this scale. And so we want to make sure that we are asking the questions as they are written, because that's what's going to give us the correct information based on evidence-based practice. So when you're asking these questions, ask them exactly as they're written. And then again, make sure that we are doing this at admission, upon transfer to a new unit, and at least every 7 days during their stay. When a patient screens as low risk, we're just going to recommend or reassess at the next recommended time, okay? Also, a quick note, it doesn't have to be every 7 days. It has to be every 7 days at minimum. So if there's a reason that we would need to ask these suicide risk questions sooner than every 7 days, maybe it's only been 2 days since they were last asked, but maybe there is some clinical indication as to why they may be suicidal at this point. So maybe they are being abandoned by their family and they're going into DHS custody, or maybe they were diagnosed with a terminal illness. You know, good reasons that you might become suicidal, right? So things can change. We don't have to wait 7 days to reassess. We can reassess sooner than 7 days if necessary, okay? If the patient screens moderate, we want to initiate precautions. If they screen high, we also want to initiate precautions. We're just going to do so with a little more urgency, right? So moderate risk, we're going to initiate all the precautions. We're going to consult psych, but we can make adjustments as necessary with, staffing. We can call the clinical coordinator, get a safety attendant as soon as possible, all of those sorts of things. But when a patient screens high risk, we are not leaving this patient alone for any reason whatsoever. We are going to stay in that room with that patient until someone else comes to relieve us. So whether that's a BHT, a safety attendant, a CTA, a charge nurse, whoever, we are going to initiate all these precautions. We're going to do the STAR protocol, the spec sheet, all the things, but we are not going to leave that patient alone for any reason when they go to the bathroom or anything. We want to make sure we don't give them the opportunity to attempt, okay? Also, another really important thing to think about is that a lot of these kiddos have been in and out of the system their whole lives, and so we want to make sure that when we are asking them these questions, we are also using our critical thinking skills. A lot of these kiddos know that if they answer these Columbia screening questions, honestly, they are going to potentially get stuck here. They're going to potentially have to go to an inpatient facility, and we all know that they don't want to do that. And so a lot of times they lie. And so they do not answer these questions truthfully. They say they are not suicidal when they are, or, there's other stuff that can be going on as well. But I would just encourage you that if you feel concerned about a patient's safety and you do not think that they are safe regardless of what they screen on the Columbia, you need to put them on precautions anyways, and you need to consult psych anyways. Better safe than sorry. Psych can come and clear them if they feel like they don't need the precautions. But for me personally, I don't want to be the one who cleared them if they do in fact attempt suicide or complete suicide, and then I cleared them and I didn't follow my gut. So make sure that if something in your gut is telling you the patient is not safe, that you continue to advocate for that patient. You do consult psych, and we make sure that the patients are safe, okay? And then when you document in Epic, you want to make sure that you document appropriately. So this is one that I see kind of get misdocumented often, and so I just wanted to point it out specifically. In Epic, when you document, is the patient able to respond? It's not that we just don't do the screening and we just, document, yes, the patient's suicidal because they overdosed, right? Like they're sedated and intubated in the ICU. And so we just document, yes, they're suicidal. Well, no, you need to think of this like the pain scale. If they can't respond to you, they can't tell you the answers, then the answer is no. The patient is not able to respond because they are developmentally delayed, because they are medically unable to answer, because they're confused. Whatever the reason may be, you want to document that. You don't want to just put, yeah, they overdosed, so obviously they're suicidal. Yes, and then answer the questions as if the patient verbally told you that that was the case. And so you don't want to do that. You just want to document, just like the pain scale, it is what the patient says it is, right? And so we want to make sure that we're documenting that appropriately. Then when we initiate precautions, the first thing that we do is we do the STAR protocol. So basically when you do the STAR protocol, what you're doing is you are removing everything from the room that you can, you are leaving everything that you can't, and then you're going to document, okay? The documentation piece is really important with this because if you think about it this way, if someone comes into the ER and they're saying, I'm going to kill myself, but they need oxygen, we're not going to take the oxygen tubing away, obviously. So we want to document that, yes, we did leave the oxygen tubing in the room intentionally because the patient needed it, right? So what you don't want to happen is, say the patient chokes themselves with that oxygen tubing and you didn't document anything about it. Then you look neglectful because you didn't understand that the oxygen tubing was a risk to the patient. And so we don't want to look neglectful. We want to say, yes, I recognize that oxygen tubing is a risk. However, the patient needs it for their medical need. And so we intentionally left it with the patient because the benefit outweighed the risk. And so you have to document those things. Otherwise, it reflects that you didn't recognize the risk and therefore were neglectful. So just make sure that you're documenting really clearly. We want to continue to reassess because, as you guys know, things change on a dime. Okay, so it could be, you know, everything's all situated, everything's fine, everything's safe. 5 minutes later, you walk back in and somehow the patient got a screw out of the wall or something, right? We want to continually reassess because things change so quickly. So don't forget that piece. It's very, very important. Some other things, you know, you want to make sure that you put the dot sign on the door, whether it's a red dot, purple dot, yellow dot, whatever. Visitors cannot bring their belongings inside their room. Okay, they can go put them in the car. We can store them for them in our safe areas. We have lockers. We have the nurse server cabinets outside the doors. Whatever makes the most sense. We want to make sure that the visitors are not taking their belongings in the room when our patients are on suicide protocol. We want to make sure we change the dietary order so that they don't get silverware or plates in their meal trays. We want to educate family why we're doing all of this. And so the BHTs usually do this part. They come and do the caregiver letter with the family, and they also do a get to know me form with the kiddo. And so if you don't know what that is, check the media section of Epic. Usually they upload it into the system. The get to know me form can be really, really helpful to you. And then of course, make sure we consult psych so that the kiddo can be assessed and provided with resources, medications, all those things that they might need for, you know, moving forward. Here at Children's, we use this color level pathway. Quick note, if you float to the adult tower, it is very important that you understand they do not use this color level pathway at the adult tower. This is specific to Children's, okay? If you go to the adult tower, just follow policy. Make sure you stick to the policy. But if you are at Children's, we do use this color pathway. So some really important things with this color pathway is that we want to make sure that we stick to it very, very specifically, right? We want to maintain as much as possible working within these regulations because they are designed on purpose, okay? So if you have a patient on level red, they can only have level red things. If they're on level yellow, they can have yellow level things in addition to level red things, okay? Just some quick things to note. If a patient is purple dot and red dot, one does not trump the other, okay? You can be homicidal and suicidal at the same time. So you can be a purple dot and a yellow dot or a purple dot and a red dot at the same time, okay? Just because one goes up doesn't mean the other comes down, okay? So we want to make sure that we are staying within those bounds. Now, also, we do understand that in behavioral health, a lot of things fall in a gray area, right? We have kids that need special accommodations for a number of things. And so if we are going to go outside of protocol for some reason, because of that gray area, we need to make sure that we do it the correct way, meaning that we need to, as a team, decide what is the correct way to go outside of protocol. So you need to, you know, reach out to Child Life, reach out to the BHT, reach out to the behavioral health manager, Taylor, myself, psych. We need to have a team that can discuss how to appropriately meet the kiddos' needs. And then after that, once we come up with a plan of how to meet those needs that are outside our current protocol, we need to make sure that we communicate that to the rest of the team, right? That way, when the kid starts asking questions, night shift knows how to respond versus day shift knows how to respond if we're going outside of the bounds. That way, we're all on the same page and we're communicating clearly to the patient and their family so that they are not frustrated or confused and we're not telling them different things because, as you can imagine, as a patient, that would be very, very frustrating. So we want to make sure we're all on the same page. We're all communicating clearly to the patient and their family. These are just some other resources that are available. This is kind of what the signs look like. If you have a dot sign, that's what the dot sign looks like. And then those are the items they can have when they're on level red. Child Life was so kind to make behavioral health red bags. So there are emergency carts on 9 West in the main ED, and then in ED East, they are in the drawers. In the hallway of ED East. So if you have a patient that is put on level red, you don't have these resources. We have the little red bags. They usually are stocked in those carts. So if you're on like the 8th floor, the 10th floor, or the 6th floor, whatever, and you don't have a red bag, you can go to those other units and get them out of the carts. You can also, if you can't leave your unit, you can also call the BHT. They will come and bring them to you. So if you have a kiddo on red or yellow, we don't want the kids to be bored, right? We want to keep them engaged, keep them entertained, because when they get bored, that's when they start acting out. So we want to make sure that they have access to these resources. So if you don't have them, ask the BHT, they'll get them for you, or you can go get them from the emergency carts on those units I mentioned. The other part of this is that we want to make sure that they are getting these items and only these items. We don't want to go outside of this for any reason, okay? No exceptions. Again, unless we're in that gray area and the team has decided that it is safe for whatever reason. Also, if you're using these items for your patients, please only use these red bag items for behavioral health patients. We have a limited supply of them, and so when we are giving them out to everyone, we want to be good stewards of our resources, right? So we have these for our behavioral health patients. They are limited as to what else they can use. And so the other toys and things like that from the zone that the other kiddos can have, our behavioral health kids can't have. So when you're going to use these red bags, please only use them for behavioral health patients because we have lots of other resources for our other kiddos who aren't behavioral health. So please be thoughtful about that. On that note, behavioral health patients cannot go to the zone, okay? It's not safe. The outside portion is not safe, and the inside portion of the zone is not safe, so we cannot take our patients up there for any reason. So please do not do that. Hopefully you guys have all seen a spec sheet. This is what like the downtime version of it looks like, but it is on Epic where you can just click the boxes and document it that way. When we are documenting that the spec sheet has been completed, I know to some of you guys this probably seems like overkill that so many people look at this spec sheet so often, but it's actually really important for a number of reasons. So the safety attendants oncoming and offgoing should be reviewing this together. The nurses oncoming and offgoing should be reviewing this together. The nurse and the safety attendant should also be reviewing this together. The nurse and the safety attendant really need to talk to each other. We need to make sure that we're all on the same page. We're communicating the same thing to the patients. And the charge nurse needs to review the spec sheet also. All of this needs to happen within the first hour of the shift change, okay? Anytime there's a change in staff, the spec sheet needs to be completed, and we need to make sure that we are reviewing it and documenting that it was reviewed within the first hour of the shift by all of those people mentioned. This is really important because if you think about it, obviously we all want to be on the same page for communication. We all want to be relaying the same message to the patient, but also the reason so many people look at this document so often is because the more eyes on the patient, the more eyes on this document, the safer the patient is going to be. My experience might be different than your experience, and so maybe when we're looking at the spec sheet together, I might feel like everything's safe, and you may think, oh no, I've seen a kid take this and use it to hurt themselves before. We probably need to take that out of the room. And I may be like, whoa, you can do that? No way. I've never seen that before, and vice versa. So the more people that look at this document, the safer the patient is going to be. That's why so many people review it so many times, okay? So the safer the better. Some things to think about when you're talking about things that could potentially be a risk. These are just some of the hot topic items, you guys. These badge reels, they are so dangerous. They make me really nervous, okay? I know that we have to wear our badges per policy. However, if you have a purple dot patient, please don't wear these in the room. If they get it around your neck, it's very difficult to get off. The string is very thin and very strong. So it's very dangerous. So please don't wear these in purple dot patient rooms. You really want to be conscious of what is in your pockets. I know a lot of nurses, you carry trauma shears in your pockets because we use them all the time. But just be really thoughtful about that, okay? Don't take them in suicide patients' rooms. If you normally carry 4 pins in your pocket, make sure that when you walk out of the room, you still have 4 pins in your pocket. These patients, sometimes they're very smart. They've been in and out of the system. They know how to get things off of you without you noticing. And so don't take anything extra in the room that you don't need. If you are a safety attendant or a CTA and you're sitting in the room, don't take your personal belongings in the room with you. Whatever is in your bag is a big danger to the patient. Please do not take it in the room. Some other really big items are the plastic bags and the trash cans. Very dangerous. We want to make sure we're using paper bags, or if you can't find a paper bag, take the trash can out of the room altogether, okay? And then anything that could be ingested, so hand sanitizer, things like that, can be really dangerous. Big Stanley cups, those make really great weapons, guys, so be really careful when they are sitting out in the nurse's station or in the hallway, whatever. And aluminum cans. Aluminum cans are so lethal and can be lethal so quickly to you or to the patient. So please do not take aluminum cans in patient rooms at all. If you want to pour it in a plastic cup, a paper cup, that's fine. Pour it in a paper cup, but please do not take aluminum cans in the patient's room, okay? If you are putting a patient in paper scrubs, they cannot keep their underwear. Not only is it a strangulation hazard, but it's also a really great place to hide things, okay? They will hide things everywhere. In the panty pocket, if you guys know what I'm talking about when I say the panty pocket, it's a great place to hide stuff, okay? In bras where the padding goes, there's a little hole on the sides where the padding is. That's a great place to hide razor blades, pills, drugs, all kinds of things. So when we are putting them in paper scrubs, we have to watch them put the paper scrubs on, and they cannot keep their underwear. We can issue them hospital grade underwear, but they cannot keep their own underwear. It is not safe. If they are on their cycle, they have to change their pad, okay? Sometimes they will hide things underneath their pad. Make sure that they change that pad out, and you are watching them do this, okay? I know nobody likes it. It's not fun. I get it, but better safe than sorry, okay? It's too important, too dangerous to not do it because we're uncomfortable or the patient doesn't like it. So we want to be thoughtful. We don't want to degrade anyone, but we have to make sure that safety is first. When we put someone on Purple Dot protocol, we want to make sure that we're doing this correctly, we're documenting correctly. There is the notification banner that turns purple in Epic, and then there's also the Purple Dot assessment, and basically this is where you're saying that they are at risk for aggression, and then you can document further about why you feel that way or what the aggression is, all of those things. What Purple Dot means is that we are saying that the patient is at a higher risk for aggression, whether that be sexual aggression, physical aggression, sometimes even verbal aggression, okay? And it doesn't always have to be the patient. It can be the patient's parents as well, or visitor, family member, whoever. And so when you have a Purple Dot patient, make sure you're using the buddy system. We always do our absolute best to assign 2 safety attendants to sit with the Purple Dot patient. Make sure that you are sitting in the room with the patient. I know that this is a hard thing for a lot of people because aggressive patients make us nervous, and I get that. But it is very important that we are sitting in the room with the patient, okay? Always put yourself between the patient and the door so that you can get out if you need to. However, you need to be in the room interacting with the patient, building a rapport with them, okay? It's really important. If you are in the room with the patient and you're building a rapport with them and they get upset, chances are they will go past you and go hurt someone else, okay? If you're sitting in the hallway and you're not engaging with the patient, you're just sitting in the hallway on your phone and you're watching the patient for safety, what you've told that patient inadvertently is that you're scared of them and that you don't care about them and they're not worth your time to even talk to. You'd rather sit in the hallway on your phone. And that's not okay. If that patient gets agitated or aggressive, not only are you the closest person to them, but you've already told them all the things they need to know that you are a great target for their aggression. So you're going to be much safer if you are in the room building a rapport with the patient, engaging with them, and you're there to notice those behavior changes early on and help them regulate early on. So that's really, really important. We also want to make sure that if we are documenting about a violent event, that we are documenting objectively. You want to use objective phrasing, objective documentation. You don't want to use subjective, opinionated things. It has to be objective documentation. Also with purple dot patients, there is an increased security presence. Nurses, you should be rounding on purple dot patients more frequently. The BHTs also should be rounding on purple dot patients more frequently. The more people are paying attention, the less likely they are to act out, just because they realize that people are more actively paying attention. If there is a situation where a patient gets escalated, we want to make sure that we document a new violent event and we objectively document what occurred, right? Were they throwing things? Were they hitting people? Were they verbally aggressive? Whatever that might look like, we want to document their behaviors in that new violent event note. And then we also want to complete a safety solution, especially if someone was injured, especially if, someone got bit or hit or kicked or spit on or something was thrown, or if someone found contraband in the patient's room or in the patient's possession that they weren't supposed to have. All of those need to go in as safety solutions. Also something to note, do not document anything regarding the words purple dot anywhere in the chart except the purple dot navigator, okay? The purple dot navigator is hidden from view from other entities. It does not show up on their My Chart. It doesn't, certain things that it is like protected information. So make sure that when you document anything regarding purple dot, that you only document that in the purple dot navigator and the places that we've talked about with the new violent events, the purple dot assessment, those types of things. We have all kinds of resources for you to use, especially if you have a patient that is aggressive or getting upset. We have impact cushions. We have Kevlar sleeves. If you have somebody who's a known biter, make sure you wear those Kevlar sleeves, okay? They're not going to keep the patient from biting you, but they will keep it from breaking your skin. So, use them. We have our behavioral health preferred rooms. There are 13 of them in the ED, 3 in the main ED, and 10 in ED East, and then 4 of these behavioral health rooms on the 9th floor. If you haven't seen them, they're really, really great resources for us. We just want to use them effectively. And so if you have questions about those things, you can reach out to me, or if you've never seen them before, we can arrange a time for you to see them and see, what you do with them if you need that. Otherwise, just, interact with your patients. That's really the best thing you can do. Interact with them, build a rapport with them, get to know them. The more they know you care about them, the less likely they are to act out. When we are discharging patients, we're always going to re-screen them using the Columbia, unless they are going to an inpatient behavioral health hospital, and then there's a specific discharge screener for that, because we already know that they are still suicidal. That's why they're going inpatient. If you are discharging a patient home and you screen them using the Columbia screening tool and they screen positive, do not discharge the patient, okay? Report those findings immediately. Put them on precautions if they're not already on them. Put them on precautions, consult psych, but you cannot discharge someone who is a suicide risk, okay? Also, at discharge, we want to make sure that we're providing education to the family. They need to know the warning signs, risk factors, how to maintain a safe environment, right? If they have firearms in the home, make sure they're secured. If the patient takes, Prozac. They're not giving the patient the whole bottle of Prozac and letting them dose themselves, right? They're giving them to them one at a time every day. Because we don't want them to overdose, right? And then they also need to know what community resources they have available, and everyone should know the suicide prevention lifeline number is 988. Very, very important. You can call or text it at any time, 24 hours a day, 7 days a week. And so our patients need to know that that is an option for them. If the patient is going to an inpatient behavioral health hospital, do not allow the patient to put their clothes back on, okay? They also should not have their belongings back. Their belongings need to be given to the transporter. This is very, very important. We don't want the patient to do anything to harm themselves in the car on their way from here to the inpatient behavioral hospital, okay? Also, kind of a pro tip, wait to review the discharge paperwork with the family until the transport has arrived. A lot of times what can happen if the family is not super on board with the patient going to an inpatient facility, and we go through all the discharge paperwork with them and then we're just waiting for transport. Sometimes the families will take the patient and leave, and they have the discharge paperwork, so it's not really an elopement. It looks like we just discharged them. So just make sure that you wait until transport arrives to go over that discharge paperwork with the family. So real quick, we're just going to talk about de-escalation. We're going to talk about the phases of a crisis. Okay, so when you have a patient and they are escalating, right? We have this anxiety phase where you would notice a change in behavior, right? We all kind of know what anxiety looks like, what anxiety feels like. But this is kind of where you start to notice that change in behavior and you want to intervene sooner rather than later. When a patient moves into that defensiveness phase, it looks a little bit different, right? You should be able to notice the change. In my mind, what I kind of think of is when you have a patient that, say they come into the ED and they have a broken leg and their parents are very, very anxious. They're asking all these questions because they're scared, right? They're saying, how long is my kid going to have to be out of school? Are they going to need surgery? Is the pain medicine working? How much is this going to cost? Do they need surgery? Yada, 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 all the things, right? When those questions shift into the more accusatory questions like, who are you to tell me my kid needs surgery? Or Google said to do this, so why are we not doing that? I don't think that pain medicine's working. Do you even know what you're doing? Those questions are how you know they've shifted from anxiety to defensiveness, okay? Their emotional brain is taking over more and more, and their rational brain is going away. It's becoming less and less. So the more defensive they get, we are moving towards risk, okay? We want to avoid risk at all costs. Defensiveness is also where you're going to get your power struggles, okay? Posturing, when we talk about posturing, I'm meaning, you guys know what that is, not the medical kind, but when someone is posturing, they're bowing up at you, right? They're ready to fight. You know what someone looks like when they are ready to fight. When you get into that posturing phase, you are getting dangerously close to risk, okay? Risk is when the patient or whoever is in this crisis becomes an imminent threat to themselves or someone else. We want to make sure that at some point after this risk phase that we move into tension reduction and we are able to regain calm, and then at that point we go in and we process with the patient. We want to make sure that we go in and we talk with the patient, because at this point their rational brain is back and they can process now, whereas when they were in that risk phase, that is when there is no rational brain, there isn't even an emotional brain, right? Risk is when they are in what I like to call lizard brain, okay? It's survival mode. They will not respond to rational thought. We need to meet their basic human needs in that moment and then wait for them to come back down from that risk phase to where they can process rationally, okay? So now that we can kind of see what those phases of a crisis are, we want to know, what do we do in those phases, right? So the most important thing I'm going to tell you is all behavior is a form of communication. It is very, very important you understand that. All behavior is a form of communication. So just because a patient can't verbally tell you what they're feeling, they're going to show you. You just have to be able to determine what it is they're trying to say, okay? When you have a patient that is in that anxiety phase at the very beginning, right, we want to identify that change in behavior early. That is why your BHTs, your CTAs, your safety attendants, they are so, so, so important. Nurses, we're not going to understand, we're not going to see that change in behavior because we are not in there with the patient like the CTAs and the BHTs are, okay? You want to be able to identify that early shift. So rely on your CTAs, your BHTs, your safety attendants to notify you, hey, this patient's starting to escalate, hey, this patient's getting anxious, and listen to them because we want to intervene as early as possible. We want to look for the root of the issue. If it's a small fix, a simple fix, let's fix it, right? It may be something that we can't do anything about, but it may be something that we can solve. This is the phase that we also want to give PRN medication in if we can. I know that it is difficult to get PRNs, kind of psych PRNs timely the way that our workflow is, but if we can get them, we want to give them here. If you wait till the risk phase to give them, it's like putting a water hose on a forest fire. It's not going to do much good, right? Also, if you catch someone in the anxiety phase and you can convince them to take medication, usually you can get them to take these PRNs by mouth, and we can avoid holding them down and giving them an injection, right? So it's always better to give them these meds kind of preemptively before we continue to escalate. This is also the phase that you want to encourage them to use those coping skills. They may already have a whole book full of coping skills that they can use. If they don't know any, teach them some, right? There's like a gabillion that you can do. So teach them some coping skills and then encourage them, remind them to use the ones they already know work for them. If they escalate into the defensiveness stage, this phase is the phase that is really, really hard to navigate, okay? And I can tell you, if you're not experienced in managing behavioral health patients and you're not used to de-escalating and observing these behaviors, you're not going to be good at this phase at first, okay? It takes a really long time to learn how to do it and learn how to do it well. But if this is something that you want to develop as a skill, the best thing I can tell you is listen to other people do it. That's how I learned all of my de-escalation skills, was by listening to other people de-escalate patients. So if you have a patient that's acting out, you don't know what to do, you call a BHT, you call Child Life, someone to come de-escalate them. Don't walk out of the room. Stand there and listen to what they say and how they engage with the patient to get them de-escalated. And then you can usually even ask them, hey, how did you know what to say to that patient? What did you notice about their behaviors that gave you clues? Usually they can articulate, well, I noticed them doing this, so I chose to do this. And you can really, really learn from that. But just know that this defensiveness phase and de-escalating this phase, it takes a really long time and a lot of work to learn how to do it very well. So if you're not good at it, don't get discouraged. Keep trying, keep learning. But you really kind of learn to navigate this phase by practice. But one thing that you can do in this phase is avoid power struggles. If you engage in a power struggle with a patient or anyone who is in a crisis, it's going to escalate the situation, okay? So it's really, really important that we do not perpetuate the power struggle, okay? The best thing anyone ever told me about power struggles is ask yourself, does it really matter? And if it doesn't, let it go. If it does matter, set the firm boundary, set the limit, and we're moving on, okay? So for example, I have two little girls. I have a 3-year-old and a 4-year-old, and I ask myself this question every single day, does it really matter, right? So if my 3-year-old wants to eat a goldfish off the floor, whatever, eat it, okay, right? We're not power struggling. Eat it, you're not gonna die, I don't care, okay? Now, if we're in Walmart and she wants to eat a goldfish off the floor, Absolutely not. You could die. We're not doing that, right? Either way, we're not power struggling. Either eat it and move along, or absolutely not. We're setting that limit, we're setting that boundary, and we're moving along. We're not power struggling about it either way. So when you feel yourself getting into this power struggle, ask yourself, does it really matter? And then respond accordingly, okay? Then if we move into the risk phase, this is the one where I know there's a lot of strong feelings about managing our safety as staff with aggressive or violent patients. We want to maintain the patient's safety first and foremost, and we want to maintain staff safety, okay? We may need to consider restraints. We may need security at this point. But ultimately, if a patient starts getting aggressive, number one, we want to make sure that we keep eyes on the patient, right? So remove yourself from the situation. We don't want you to get hurt, but don't run out and shut the door, right? We want to make sure the patient doesn't kill themselves. That's very important. But don't stand in the room and let a patient hurt you, okay? So we want to make sure that we maintain our safety as much as possible, okay? You don't come to work to get beat up. But if for some reason a patient gets a hold of you, the number one thing you need to do is make as much noise as possible. Scream, yell. If there's a table close enough to you, kick it over, right? You want to cause as much ruckus as possible, okay? Get as much attention to the room as you can, okay? If the patient has you by the throat and you can't make any sound and you're up against the wall, hit the wall, kick the wall, push the code blue button, whatever you're going to do to get attention to the room, you've got to get out of the situation, okay? Please, please, please don't stand there and let a patient kill you, okay? Don't stand there and let a patient hit you. Get out of the situation. If you have taken the nonviolent crisis intervention class, great. If you remember those skills, use them to the best of your ability in that moment. If the patient is violent, so the nonviolent class is designed for patients who are non-violent. Currently, we see a lot more violent patients than we do with our non-violent, and so hopefully in the future we will be getting more resources for you for how to manage violent patients, because we have seen an increase in that significantly in the last few years, which is it's very difficult, but we are working towards developing some more resources for all of you that will help with those more violent patients that we see. But in the meantime, get attention to the room, call for help. We can call security as needed, and then of course don't let a patient hurt you, okay? Get out of the situation as quickly as possible. And then when we move into that tension reduction phase, we want to make sure that we allow the patient to stabilize. It takes 45 minutes for the human body to come down out of an adrenaline state, okay? So that is talking about the patient, but it's also talking about you. So if you get into a verbal altercation with the patient, or the patient attacks you or whatever, go take a minute, right? Give yourself a few minutes to regulate. 5 minutes, go wash your face, do something, ask for a break for a minute, because you do need that time to stabilize. Otherwise, you're going to go right back in the room and reinstigate the patient, even if you don't mean to. But after everybody's stabilized and everybody's regulated, at some point we do have to go and process with the patient. We need to understand, hey, what caused you to get upset in the first place? What did we do that made things better for you? What did we do that made things worse? Is there something we could have done that would have helped you that we didn't do, right? We want to ask the patient those questions. Sometimes they'll tell you to F off, right? Like they don't have anything positive to say. And that's fine. We can document that. But sometimes they'll give you a whole blueprint for how to navigate their behaviors. And when we do get that information, we need to make sure we take that back to the team and we debrief about what we identified as ways to respond in the future, right? Because if we can prevent someone else from getting hurt in the future, or this incident from occurring again in the future, we want to do that. So you got to make sure whatever information you find out, that you share that with the rest of the team, so that we can build on that knowledge for future incidents. And so that's kind of how you want to manage those different phases of a crisis. So this was just a very brief, quick snapshot of how to take care of behavioral health patients. You know, just a reminder, a quick guide. If you have questions about anything that was stated, please feel free to reach out to me. Ask your leader for my contact information if you need it, or my office is on the 9th floor. Feel free to come and ask questions anytime. You can email me anything. I'm here to help you guys navigate how to take care of our behavioral health patients. Thanks for listening. If you have questions, I'm always happy to answer. Thanks, everybody.